everyone. You are from all over the world. This is so exciting. It's really great. I'm Samantha Weaver. I'm with the AOMT, and today we have such a special guest. We have a lot of people coming in, which is really great because this is such a great topic. And I know you are here because this is of interest to you in your clinic and what you're doing. Today, Eyal Botzer is here with us, and he is such a special person. He is a pediatric dentist. He's going to talk about buccal and lip tie. And Eyal, I'll just let you introduce yourself.
So today we're going to talk about lip tie and buccal ties. What do we know about it, and the clinical relevance and current evidence that there is there. I hope I can go over the literature that exists, because there's not much of it. And then we'll have some time for questions. So I'm the director of pediatric dentistry at the Tel Aviv Medical Center. And let me see if it works. It moves. Yeah, this is Tel Aviv. This is our hospital here. It's a photo from a few years ago. Tel Aviv looks differently, both for two reasons. One is the missiles that we got hit in the last 2 years almost. And the other thing is there's a lot of constructions, a lot of high rises, and you are more than welcome. A disclosure, I'm the co-founder of BAM Medical. We invented the LiPer device. Now it is called the tongue gym. I'm no longer involved with the company. It's a tool for tongue training. If any of you seen it or used it, I love it. I treat patients of all ages with tethered oral tissues, with and without frenotomies, and I get paid for it in my private office, so I may be not so objective, but I also the salary director of pediatric dentistry unit at the Tel Aviv Medical Center. And in 2019, we opened a multidisciplinary research and treatment center where we do treat patients and either get no gain whether we do any kind of invasive procedure or not. And in 2024, 2024, I co-edited a book in Hebrew. It's called Mahakesher, meaning the connection between tongue tie and oral dysfunction or oral function on our body and our health from infancy to adulthood. This is our center. It's a multidisciplinary team. We have body workers, lactation consultant. Here we have a visitor from Poland, Anna Kotlinska. This is the room where the mothers are breastfeeding. And on the side, let me go a little bit back. And here is the procedure room. And we have a big waiting room because we see a lot of patients. Once somebody comes in, we see about 170 patients, babies a month. And we examine them first by the lactation consultant, then they provide their recommendations. Following that, we have a dentist examining. He assesses the anatomy, and then checking for signs and symptoms as pain, high palate, coated tongue, etc. And then establishes a diagnosis. Well, following that, we are discussing whether the patient, what is our next stage with him? Only lactation consulting, tongue training, body work, etc., or reevaluation following that, or start with a frenotomy and then always get a follow-up by the lactation consultant, maybe body work or reevaluation. So every patient gets their own treatment. We also have an on-board osteopath, but unfortunately, it's not on the same day because we don't have enough room for all of us at the same time. If frenotomy is indicated, it is done right on the spot, and then the lactation consultant is following the patient. Right here, this is our procedure room. We have the computer here, and this is where I do the procedure. We have this kind of magnifying lamp. We don't need a dental chair, and the assistance of our dedicated nurse. And this is where the magic happens. We release the frenula with our tongue, sometimes lip ties. I must say, we've never released a lower lip yet. and release the tongue up to the genioglossus muscle. We use scissors, and we may discuss that, or if you have questions after that, I'll be happy to answer. Okay. So I just want you to invite you to our meeting that is going to be in November with a very special guest. Among others is Samantha. It's in Jerusalem. And if you speak Hebrew, some of the lectures will be in Hebrew. Please scan this, register, and come. Jerusalem is amazing. And the program is going to be also amazing. Okay, so let's discuss lip and buccal ties, clinical relevance, and carrot evidence. When Samantha asked me to do that, I immediately called my friend and I asked him, hey, what can we do? And immediately he was very responsive. I put in some of my presentations, and this is our lecture now by ChatGPT. So what are lip and buccal ties? So lip tie is a restrictive upper labial frenum. Wow. Buccal tie, tissue bands between the cheeks and the alveolar ridge. And there are anatomical variants, not always pathological. The lip tie, buccal ties, where you can see here on the sides. Those photos are from our book, and we have hundreds of photos in the book, but it's in Hebrew, so I advise all of you start learning Hebrew, or we'll do it in English, I don't know. So, why do they matter? Suspected to affect breastfeeding, the latch, the seal, the nipple pain. Buccal ties may interfere with cheek mobility and oral seal, and often released with tongue tie procedure. There is a survey by Sourasky and Richard Baxter on buccal ties. According to ChatGPT, they surveyed over 1,000 professionals, and there is a wide variety in diagnosis and treatment. Some reported that there is improved latch and maternal and discomfort in the maternal discomfort following the release, and the conclusion is more research is needed. About buccal ties, again, very limited literature, mostly anecdotal evidence. Some clinicians report improved latch or oral seal, and there is no validated classification system. And the expert opinion is that intervention, can you see it? Something went wrong on my computer.
Yeah, we can see it. We can see it.
Intervention is that should be function-based. Not all visible ties are pathological, and evaluation by lactation consultants, speech-language pathologist, myofunctional therapist is essential. Okay, so the summary or take-home message, let me see if I missed any. The expert opinion was intervention should be function-based. Not all visible ties are pathological, and evaluation by lactation consultant, speech-language pathologist, or myofunctional therapist is essential. About the lip tie, again, literature overview is that case reports suggest benefits from breastfeeding post-release. There are no good RCTs, and there is a variability in classification. There are several classifications like the Kotler, the Stanford scale. And the summary or our take-home message is lip and buccal frenuli are normal variants. Intervention is only indicated when function is impaired. And we always say form and function. This time form is leading, function is leading. If there is any functional issue, look for the form and try to fix it. And more high quality research is needed. So let's talk about buccal ties, buccal frenums. Let's talk about what do we know about it. What is my experience with them, and when should I intervene? So there is an article by Richard Baxter, Robin Welsh, Lisa Leahy, Chad, and Surush, and they examined only 466 professionals, not 1,000 as ChatGPT thought. And it's a first peer review publication focused specifically on buccal ties. And they asked some of our peers to give their opinion on that. They found wide variation in diagnosis, treatment, and reported outcomes, and they suggest a good classification for buccal ties. Some clinicians observe functional improvement after buccal tie release, and the bottom line is evidence is still preliminary. More research is urgently needed before clear guidance can be established. So this is what we know, what I know from the literature on lip ties, on buccal ties, I'm sorry. What is my experience with that? So I did only a handful of neonates and that I performed buccal frenotomies. It's a simple procedure as lip and tongue. And I do that again, I'm using scissors, following some anesthetics. Many times I palpate the buccal frenula, and it's a normal anatomy. And after performing the labial frenotomy, I feel no restriction. I guess it's mediated by the fascia. And from last week's lecture by the body workers, where she mentioned that following the lip tie release, she feels the skull is getting, I don't know if molded, or she feels the tension goes away, and she recommended not doing the release of the tongue immediately, rather wait a little bit. Okay, so as I said, it's mediated by probably by the fascia, that I feel that the buccal ties are being sometimes even disappearing, the palpation wise, following the release of the labial frenum. Okay, in a few cases, I released the buccal frenum in separate sessions, and the mother reported in breastfeeding. This is my experience. My understanding is that it may help in selected cases. I'm not rushing into it. I'm examining every patient. So when should I intervene? These are my guidelines as of today, August 23rd. So I'm still learning. Okay. And I guess once it feels tight, breastfeeding is not improving following the tongue release and the lip tie release. If the lactation consultant insists, and these are my decision helpers when I decide whether to release the buccals. And so we are looking for more research, and I'm sure it will come. Hopefully from our institution, because we have so many patients to go, but to see, and I hope this is one of our topics to do research on. Okay, so let's talk about lip ties, labial frenums. Again, what do we know about it? When should I intervene? What happens if I do not revise? How do I do it? And the definition of labial frenum is a fold of mucosal membrane connecting the labial mucosa to the alveolar mucosa at the midline of the upper and lower arch. We'll discuss maybe the lower arch later. And if we're trying to get into a deeper definition, which I must tell you, I didn't really understand it. The maxillary labial frenum originates as a post-eruptive remnant of the tectolabial bands. If there's anyone here that can help me with that, please do. I know it's an embryonic structure appearing at approximately 3 months in utero and connecting the tubercle of the upper lip to the palatine papilla. This is the tissue. They say here it's only a mucous membrane. I'm sure there is fascia in it. I'm sure there is. And so far, we've been using the Kotler classification, 1, 2, the one that is on the non-keratinized surface, 2 getting to the keratinized gingiva, 3 on the keratinized gingiva, and 4 wrapping around or getting to the top. There's another classification. There is a Swedish research from 1994, and it's not exactly the same classification. One is before the mucogingival line, and the other two are in the mucogingival line, and the fourth one or the third one is going around into the papilla. And what they saw is that percentage-wise, we have 76% in the mucogingival line, and on the keratinized gingiva, I'm sorry, and 16.7% are getting to the tip or maybe to the papilla, incisive papilla. So we're talking about 93.4% of frenums, labial frenums, are getting to the edge of the alveolar bone. So this is normal anatomy. There is another classification by the Stanford team from 2017, where type 1 is insertion of the frenulum in near the mucogingival line, as you can see here. The other one is insertion along the mid of the gingival line, equal to the type 3, I think, of Kotlow, and type 4 insertion is along the inferior margins of the alveolar papilla. Where do we have? We can see it here. And can continue to the posterior surface, meaning all the way to the papilla, to the incisive papilla. And it's been studied also by a group in India in 2014 on adults. They examined regarding also the frenum and the shapes or the types of the frenums. And they examined not only not the insertion of the just the shape. So let's see how many shapes of frenums there are in adults. And we'll start with simple frena, a single one, a double, a triple. These are the easy ones. Then you go to a frenum with an appendix on the labial third, on the middle third, as you can see that, and on the alveolar third. To me, these may hint of a trauma during the life of that patient. And then they have tectolabial frenum. Remember, I'm still waiting for you to explain me what is the tectolabial frenum. We have a simple one with a nodule and one with an appendix. There are more types. Again, this is what the tectolabial bands are. We have frenums with a nodule on the labial third, on the middle third, and on the alveolar third. And sometimes we have multiple nodules on the frenums. Again, is it trauma? Is it small salivary gland that is on the frenum? I don't know. I haven't seen any research on that or any histology on that. Are these nodules? What are these two? We see them all the time. We have new types of frenums with a nichum, I don't know how you say it, and one which is an inverted Y frenum, a bifid frenum, a trifid frenum. And they summarize all the types. Let me summarize it for you. We have 73% are normal frenums, and 27% may have trauma or had some kind of an appendix or a nodule. It's pretty much in coherence with the percentage of trauma to the upper lip, to the upper teeth in Israel anyway. A lot of children, until they're getting to become adults, are having trauma to their upper lip, and some of them are tearing the frenum without my help. So let's talk about frenum and diastema. A lot of times, the clinicians recommend newborns labial frenotomy to prevent a diastema. And what is the midline diastema? A diastema is defined as spacing between the maxillary central incisor. It is common and desirable in the primary and mixed dentition. If there is no diastema in the primary dentition, there are almost certainly going to be crowding in the permanent dentition. The lack of diastema, as I said, potential crowding. The etiology of a large diastema, more than 2 millimeters, is not the frenum most of the times. It can be a deep bite, tooth size discrepancy, large frenum, and sometimes extra supernumerary teeth or missing tooth. They all can cause the fact that the teeth are not aligned and there is a diastema between the teeth. The treatment may involve a combination of orthodontic treatment, sometimes aesthetic veneers or crowns, and surgical removal of the enlarged frenum after the completion of orthodontic treatment. Our face are growing downward and forward, and we expect the frenum that is attached during infancy to the alveolar ridge to start and as if it's climbing up. It moves apically with age in most cases. And the relocation of the reattachment and in the attachment in the apical direction.
Advantage card.
Right.
Again, the relocation of the attachment in the apical direction is usually accomplished by normal vertical growth of the alveolar process. If nothing interferes with that, such as maybe, let's say, a pacifier, it should happen in all children. So if we examine newborns, we see that 94% of them have a frenum that is attached to the attached gingiva or even to the incisive papilla. In the deciduous dentition, diastema is normal. At the age of 6 to 7 years of age, 98% have a diastema. It's normal. At the age of above the age of 12, only 7% have a diastema. So we see a huge reduction in the diastema according to the growth and development that it should have. And there are many etiologies for diastema. An indication for surgery is only after the eruption of the permanent canines. Let's see, when the child is 7 years of age and the teeth are erupting, they are erupting laterally to increase the size of the upper jaw. And then we have a decrease of the size of diastema once the lateral teeth are erupting, and when the canines are erupting, it should be closed if growth and development are okay. So I'm not rushing into the release of a labial frenum, unless, and we'll discuss it soon when I do the release. And let's go a bit in history, the clinical observation relating to the normal and abnormal frenum labis superioris. John Taylor said, those of us who oppose to the surgical removals of frenua, mainly that the so-called abnormal frenum is not the true cause of the spacing of the maxillary central incisor or cause of and effect relations. We believe that the space may be a result of number of causes, among which are, and again, let me repeat that. From infancy until the age of 10 to 12, the diastema is normal condition. Tongue, finger, lip habits, a pacifier may produce a diastema because the function is not working well. Endocrine dysfunction, hypopituitarism causes an overdevelopment of the arches and consequently spacing of the teeth, congenitally missing teeth. As I said, there is not so many teeth in the upper jaw, so spacing and the development of the jaw is okay, then we'll have spacing. A short upper lip accompanied by anterior dental protraction. If the teeth are flared outwards, they will expand and they will have a diastema. A deficiency in tooth structure, and there is ethnical diastema. I'm not rushing into blaming the frenum for the diastema. If we have maxillary frenum abnormalities, we can see that in all kinds of syndromes, like in holoprosencephaly, we have a missing frenum, and I've examined thousands of babies. I think about 6 or 7 I've discovered this anomaly. And they have issues sometimes in their brain development because when the body is being formed from both sides as in utero, sometimes there is an overlapping of the central side of the lateral sides, and then we are missing the frenum. In other syndromes like the Ellis-Van Creveld, there is fusion of the upper lip to the maxillary gingival margin, and orofascial digital syndrome, there are multiple freni. This is a case that I've discovered with no frenum whatsoever, and when we did an X-ray, we saw there's only one central incisor. It is called central incisor. There are all kinds of syndromes, or maybe it's one syndrome, but different presentations. The single incisor, sometimes we have no passages of the nose, a very narrow palate, as you can see here. So these are syndromes. We may find them when we examine many kids. This is another very rare case of upper lip tie. It was published, when was it? I think, it says here, 2018. Upper labial wrapping into the hard palate and anterior premaxilla causing alveolar hypoplasia. And you can see this patient and look at the CBCT or the CT that he went. Look at the dimple here, how deep it is, and then 10 months following that, things have been improving. So these are rare cases, not the day patients that we see, but when we see them, let's remember that we have extreme cases. So why did we even start talking about a labial frenum regarding breastfeeding? So I remember in 2009 when we established the IATP, and Roy Fuhrer from Israel said, hey, you must examine the lip. There is almost always a restriction there. We looked at him as if he's crazy. And then in the literature, what I could find is this quote that in 1948 in Japan, Shizumu and Matsuda also reported that there is an increase in suckling abilities after frenotomy of both the frenum linguale and the frenum labii superioris. They described that following a release of the labial frenum, there was improvement in breastfeeding. And this is, for me, the first documentation that I know. And then a lot of clinical experience from other clinicians, such as Larry Kotlow, of course, Roy Fuhrer. It became common practice, but there is hardly any research behind it. There are works of Bobby Geharry, but nothing is separating lip tie from tongue tie release. So we do see there is an improvement in suckling ability in breastfeeding, also from Buccal, but nobody separated and did any double-blind research on lip ties only. We tried to do that 15 or maybe 16 years ago, but it's very difficult to do it at double-blind research. People know when the lip is released. And then came an article by Francis Mimouni from Israel and his group, and they compared what's the literature on upper lip tie and breastfeeding. And their conclusion is that there are no RCTs found, and the evidence for routine upper lip tie release in infant with breastfeeding difficulty is poor. The classification system proposed by Larry Kotlow has not been found reliable, both in terms of intra-observer agreement and in terms of predicting the severity of breastfeeding difficulties. And I agree with that. It's not connected to the breastfeeding difficulties. It's good for us as a mean of describing in the chart what we saw or discussing it among our peers, but how the function of the tongue of the lip is not related to where the insertion and the origin of the frenum are. And then came the article again by Suruch and Richard Baxter and Ashley, and they examined 109 children, most of them in the primary dentition. And because there is I was taught, don't touch the upper frenum because you may cause a scar tissue. And do it only after the release or only after the orthodontics, because there will be formed a scar tissue. The teeth will not close the diastema. Don't do it. This is how I was brought. And I guess still being taught in dental school. And thanks to their article of Richard and Surush and Ashley, they did upper labial frenotomy with the diode or CO2 laser with local anesthetics only. And the outcome was that they did see a closure of the diastema in the primary dentition and in the mixed dentition. Actually, this is something that we're expecting to happen with normal growth and development. And the conclusion was frenectomy is associated with cosmetical and oral hygiene benefits, and when performed properly, does not impede diastema closure and may aid closure. Technique and case selection are critical to successful outcome. And I definitely agree with that. What drew me into this dealing with lip tie was a very strange case. At first, like I told you, when Rui Fuhr said, look always on the lip, I said, everybody has a frenum. Why should I do anything with that? But we did know that nursing blister is a sign of compensation. And then happened, I saw this patient in my office, and as you can see, he had two nursing blisters, one here and one here. And this was the first case I could see the relations of the blister to the frenum. As you can see, it's a rare case of two labial frenums. And I released that, and breastfeeding was okay in the first place. So today, the signs for me to do a release of the labial frenum are, first, the signs of restriction, nursing blister. This is an amazing callus, and these are very, very impressive blisters. So this baby is working very, very hard. And as I told you, I always have a lactation consultant to escort me or to refer the patient. So I know they got a good consultation whether how breastfeeding is going. But then I saw a baby born with a blister. He haven't had a chance to breastfeed even. And look what he had. He had a sucking wound on his finger, on his arm. He was sucking on his arm as a in utero. Isn't that amazing? And we know that the upper lip does have a role in feeding. That's what I know. Even some of the lactation consultants says it has no meaning, or we can always overcome it. The lip should not be tucked in like here. It should be flanged outwards. I'm not a lactation consultant, so I have no idea what. But this is something that I know. And when I question the mothers, I ask, is there a wound in the on the interface between the nipple and the areola? Does the baby open his mouth wide or not? And this helps me get to the diagnosis, whether to do the release of the upper lip. Another sign is I'm trying to cover the nostrils, and I see if there is blanching of the tissue. And sometimes when we see there is either tenting or a clefting of the upper, let me go back, of the upper of the alveolar, alveolus. This is a sign for me that there is a lot of tension here. The muscle wins over the bone growth, and this is a sign to consider it release. So when should I intervene? If the lip does not flange upwards, or the mother complains of the pain next to the nipple. And once I heard the lactation consultant telling the mother, okay, so try to rotate the baby, whether clockwise or not, and see when the lip is moving on the nipple, whether the pain moves with that. But these are the tricks of the lactation consultants, not mine. And again, when the lactation consultant recommends, I will consider releasing the lip. On toddlers, the reasons for me to do the release are because I know that growth and development will end eventually get the frenum go up and the diastema will be closed in most cases, not on this case on the left here, on the right here. So when the parents are unable to clean the teeth, look at this patient. You cannot separate the upper lip from the teeth. They cannot breastfeed. They cannot clean. And this baby probably is being fed during the night and cleaning is not occurring. So this is one of the rare cases I would do. I must say I've seen tens of thousands of babies and children. I've seen maybe 6 or 7 cases like that. Very, very rare. And cavities are reasons for us to intervene. Or something like that. Here I can definitely blame the frenum. You can see how cleaning is impeded here. And again, with oral hygiene and feeding practices, but this is a case to do the release. Now, what about here? Is the frenum the cause of cavity or not? And I question whether the baby is, or the child, what are the feeding practices, what are the cleaning practices, and this goes into the considerations. I wouldn't really, to me, it doesn't seem the reason for the cavities here. And if the baby is behaving well when they brush his lower teeth, and when they come to the upper teeth, he resents, then it may be a reason for me to release. So as I said, the frenum is expected to stay in place while the face is growing downward and forward. So you can see here, they didn't brush well. You can see the white spot lesion here, a very wide and type 4 frenum. And as growth and development occurs, it climbs up. Like we said, there's only 7 chance of diastema after the age of 12. So should we treat the 100% of newborns with a frenum? I don't think so. And this is how it grew. And there's also even a little bit of crowding in this patient. There are 11 or 12, and I don't know if they will have enough spacing for the canines. So if I get a referral from an orthodontist, I would do the release. And here's a case where it's not, I didn't do the release here, but I did follow the child at the age of 2 years of age. They went to a surgeon and had a frenectomy. They did a very invasive procedure, but look how wide it is. It's not the frenum that prevented the diastema. You will have orthodontics and other of the options to make the aesthetics better. But I don't think doing it at an early age, well, it won't hurt. It will hurt, I'm sorry. It's a painful procedure. But maybe for the conscience of the parents to say, hey, well, I'm not sure about whether I would do it or not now. It will be interesting to hear our friends here. I saw Milt here. Let's see. And as I said, trauma is something that awaits in Israel. It's about 50% boys and girls are the same percentage. And some of them are doing a great surgical job on their upper frenum. So how do I do the surgery? Local anesthetics. I use sometimes a hemostat. I think today I'm using on most patients, not on newborns, but most patients following the anesthesia, I'm using a hemostat to do it as a crush tool. Like I said, I'm not using lasers. I press the scissors onto the bone and I release the frenum on the bone, not in the middle of the frenum. And immediately following that, I'm pressing the lip to the bone, because there is a stage in trauma when the blood vessel is cut, there is a constriction of the blood vessels, so bleeding is minimal. And then if you do it this way, it will rarely reattach. And this is a case, and you can see there is white spot lesion. It's very difficult to clean. So this case went into surgery. After local anesthesia, I clip it, release it all the way to the vestibule. And this is the healing. I must tell you that there is a practice in releasing lip ties. And again, it has not been studied. We have a muscle that is stretching the nasal septum. It is called tensor nasi septi, which is kind of straightening the septum and enlarging the nostrils. This is another thing to be on the research list, whether releasing it and getting all the way to the nasal septum and to the maxillary tip, not tip. There is a small bony, don't remember the name now. Releasing this muscle all the way to the bone or not, I don't know. And this is how I do it on a newborn, following some anesthetic. Usually I use topical anesthetic, and I press the scissors on the bone, and I release the tissue up to above the mucogingival line. And then I press on the tissue. Rarely does it bleed, and that's it. It's a simple procedure. So from my experience, with the right cases, there is a significant improvement in the mother's report that the upper lip is flanged outwards, and they immediately describe that the mouth opens wider. This is like with the feeding a minute or 2 minutes following the procedure. And probably there is fascia mediated. As I told you, we see the release of the buccal frenum that are being released, and I've observed that there's less aerophagia, and we do know by the work of Giovanni Olivi and Hand and from Australia. Giovanni is from Italy, and Hand is from Australia, that there is a less aerophagia in other GI symptoms, even on bottle feeding. Now what do we say about lower labial frenums? I've never released that on a newborn, but recently or on a child, because if there is an issue of gum recession, I refer them to a periodontist. But recently, really recently, we see Shireen Lim. I recommend everyone to go into Airway for Kids, Health for Kids on Facebook. And she started her journey on lower lip ties, and I'm fascinated to see her descriptions and documentation. Interesting, maybe in the future we discuss that. And she says that she sees the same effects of tongue release following the release of the labial frenum. And again, it leads me to think it's all about fascia. And again, there's always something you've never seen, like these frenums, and they are actually, it's a syndrome called the pterygium popliteal syndrome. And again, always surprises. Then I had another case of double labial frenum with double nursing blister. So again, like ChatGPT said, we need more research, and we have our clinical experience, which is always good to improve by research. And I saw this thing and I said, listen, we always have to pull the right card at the right time. The twins. Thank you very much. That's it.
Thank you so much, Eyal. I think we have such a wide group here, people coming in from a functional perspective, certainly a lot of dentists, doctors who may have had some training, some exposure. Others are looking at breastfeeding and speech, and obviously the myofunctional disorders. This is the Myo Coffee Klatsch. We have a lot of functional insights. So I would love to open this for questions that you might have. What areas in this presentation is something that you would like clarification on? And we also have other experts here in the room who are doing this frequently. Milt Gav, you as a periodontist have a lot of insight into that labial frenulum procedure and what to expect, etc. And looking at the literature, it is always this kind of balancing act between what is in the literature and what we see clinically and functionally when we release these ties. So this is something that I would love to open up with your experiences, etc.
Milt, we're all looking at you.
Oh, I'm looking at me. I'm sorry. I didn't know you want me to talk. Hey, great presentation, Eyal, and good to see you. I hope well, I know you're probably going to be in Switzerland, so hopefully we're gonna see each other. Good presentation. I think a lot of it has to do when you look at studies and everything else about lip ties, right? How it's done, and that's a big deal. So what you're doing is, with scissors, for me, it's a little more difficult just because in order to get down as close to the periosteum as possible, which is a very big deal in preventing reattachment, because a lot of people that I see, they're doing it in the middle of the frenum like you would do on a tongue tie, which is ineffective, is more painful, and they are dissecting underneath the lip instead, disengaging that frenum from the actual periosteum in the area that is necessary to prevent reattachment. So, and it is harder, in my opinion, with scissors than lasers or scalpel. I've been doing these procedures not on babies, but when I started as a periodontist, as a surgeon, I've been doing those procedures in children and adults for 37 years. And one of the biggest things was that you have to go down, I used the scalpel at the time, go down to close to the periosteum, so not only fibers that can reconnect and form scar tissue. So I'm glad to see that although you're using scissors, you are doing that procedure the proper way to prevent reattachment. But in my practice and in those studies that you even mentioned, if you look at how the procedure is done, is not done the way you are doing the procedure. And that to me is the thing that when I talk to pediatric ENTs, we're talking about it all the time. They told me, they said, Milt, the release on an infant of a lip tie or a lip frenulum, it should never be done. It's painful and it is completely ineffective. And that's what the studies are shown. And I tell them, you're right. The way the pediatric ENT or the pediatrician is doing the procedure, it is painful, it is ineffective, and it doesn't change anything. But if the procedure is done properly, like you showed, even with scissors, then you have a lot better procedure that it does not bleed a lot, that is very effective, and is almost pain-free. So thank you for presenting that. It becomes even harder, I think, with buccals.
It's not that difficult with buccals. You need to just stretch the lip. I've seen several cases done on lasers, and to me, it was much more difficult than with scissors. The tool is, you are the tool. You are the tool. And like I said, when you do it on the bone, it rarely reattaches. I can count a handful cases of super healers that it reattaches. And I hardly give them any post-surgical exercises on newborns. And when I have a teenager or a child, I do, for orthodontic reasons, I refer to periodontists or oral surgeons. I know you need to go under into the fibers, into the circumferential fibers and release them. I don't do that. Let me help them breastfeed. So
Sounds good.
Last week we had an osteopath in our group talk about doing the labial frenum and waiting 24 hours. And this is, again, the difference between clinical and research-based approaches. So in her experience, the osteopath, she felt, and the fontanelle was allowed to open following that labial procedure. But if you go in and you do a tongue tie at the same time, there's a contraction force that could inhibit that opening action of the cranium. So I actually wanted to ask if there was any osteopaths in this group who have had similar experiences. And this is somewhat of the timing between the labia and the tongue, if they both need to be released. So that's something that I'm curious about, if there's anybody here who is and has had experience with that. And if not, it's something that would be to consider between, we're looking at bone growth, the cranium, you're talking about this downward and forward growth. And then there's this other part of it, which are the sutures of the cranium that when released early can really move more fluidly. So you mentioned that you don't recommend doing the labial release when you see it if there aren't any functional issues. Is that right, Eyal? Or do you want to clarify that?
I'm not running around the streets and collecting patients to start and decide whether to release anything, because I'm getting referrals. And the referrals for a young child, whether he has feeding issues or speech issues, there is hardly any scientific references on the lip release for speech or for feeding. But sometimes if they cannot close their mouth on a spoon, for example, at a certain age, I'm the technician of the professional. I'm the technician of the speech pathologist, of the myofunctional therapist, and we discuss it between ourselves. I love to do surgery, and on the other hand, I hate it. If they can get along without me, it's much better. So I'm therefore as a part of a team, and this team gets to the decision and we'll do it. And I have a lot of great experience with releasing lips on patients, but I'm not the initiator of the release. It's either the orthodontist, it's the myofunctional therapist, it's the speech pathologist. When it's the mother, unlike on tongue tie, when it's the mother of a child or of a teenager, not when it's a matter when it's a matter of a newborn, then I'm all with it. But when it's a matter of an older child, no.
Yeah.
Only if he doesn't make it for brushing or cleaning the teeth. Like I said, and I have, as you saw, I have follow-up of kids now, they are in their 20s, that I did not do the lip because at first, like I said, I was much more reluctant to do that. And what happens? The diastema disappears as they grow, and they didn't need any orthodontic treatment. So growth and development and nature is our best healer. I'm trying to avoid my expertise, but when I'm needed, I'll do it happily.
Yeah. Carol, do you have a question? Unmute yourself. There you go.
I do. I have a few questions. I work primarily with babies with torticollis. I collaborate a lot with a lactation consultant, and we have a local pediatric dentist that does releases a lot. And, I wonder if it's a little too much. Is there a cutoff time on an infant where you would not recommend doing a release of the lip or tongue?
Not really. The question is why we are doing it. If he has breastfeeding issues, as long as he's breastfed, it works. And indeed, I can see the signs and symptoms, and I get into the decision that it may, like I said, if the lactation consultant is there and I trust her, and I'm always for doing it because they have problems. If they did all the trouble to get into my office, they need help. So I'm always for doing it, unless they are talking to me. The child is breastfed beautifully. I don't want him to have a diastema when he's older. That's not a consideration, in my opinion, yet.
So if they're not breastfeeding, let's say, so for example, I have an infant who is 10 months old, not breastfeeding, bottle feeding, has just open mouth posture all the time, drooling, always congested. I've suspected for a long time that she may have had reflux. Torticollis is not resolving despite my most aggressive treatment for 6 months, seen a chiropractor, everything. Would this be a baby that because, the tongue is really, the fascia connects our whole body. Would this be a baby that might improve if you release the tongue? Because she has a
Yes,
lip tongue and a tongue tie.
definitely. I would definitely consider that. You describe a
Okay.
lot of issues, and he's been treated by the right professionals, and things are not not improving. So
Yeah.
it's definitely is an option. I would work first on trying to do his oromotor exercises to close his mouth if it's possible during sleep and so on. But yes, it definitely is. And I do have children like that with great improvement. But we are talking about not the amount of kids at 10 months old that are suffering from such a condition are not so many. But when we see them, the newborns with a lip frenulum, we see them all. It's 100%. So looking
Yeah.
for the and the problems to solve.
And do you see many babies with torticollis that
Oh, a
are
lot.
with lip ties and
A lot of them. And in our book, we also describe 2 cases, not of babies, of adults. And I hope our article will be published in the near future of 3 cases. One of a woman of 68 years old, a 9-year-old child, and someone in the age of only his 30s with torticollis that improved dramatically following a tongue release.
No way.
Dramatic in the office, and then, but there is some relapse following healing. But amazing cases. It's in our book, and we are now in the almost finishing writing the article on that. So torticollis is definitely something to release the fascia.
Perfect. Thank you.
Nick Moore, if you want to come on, your hand was raised. If you're there, unmute yourself. If not, we'll move on.
Oh, can you
There's-
see me?
Yeah, got you. Okay.
Perfect. So Samantha had asked me in previous weeks of our Myo course for me to share my story. If you'd like, I can still share that quickly.
Yes, it's actually a really interesting story because it's kind of an unusual circumstance. And then we are running out a little bit of time, so go for it.
I can be quick on it. So I'll give you a little background on me. So I am a general dentist, and my wife was pregnant and she was having a really rough pregnancy. And during that pregnancy, I just happened to find Richard Baxter's book, Tongue Tied, and read it cover to cover. And that weekend, just happened to find out that Chelsea Pinto of the Breathe Institute was doing a Breathe Baby course that weekend. So I jumped on it, took the course, and just learned everything I could about tongue ties and started seeing babies. And something in me just told me when my daughter was born, she was going to have issues. Well, we ended up in the NICU, and right once she was born a month and a half early. And so they said, "You're going to be here for a while." And after the first couple days, she was off of everything. All she had to do was be able to feed, and we'd be able to go home. And I checked her tongue. She had a beautiful tongue. Everything moved just how it was supposed to, but her upper lip curled in. And anytime she would try to latch on to mama, it really, really hurt. So we had to supplement with breast milk. And even with a bottle, milk would just pour out of her cheeks on either side. And so I told everybody in the hospital that would listen. I told the nurses, the lactation consultants, the doctors. Honestly, I told the janitor, I said, "She has a lip tie. Can I please bring my laser and correct this?" And they said, "No, lip ties have nothing to do with feeding." So they got to the point she had to drink 60 milliliters, which was 2 ounces of milk, and drink that in 35 minutes. And even then, most of the milk ended up on her shirt, or she just couldn't drink that. And so finally got to the point the doctors started telling me, "She's going to be a failure to thrive, baby. You're going to be back in the hospital." I got to the point I was kind of pouring some of the milk out because I knew they were wrong. So the day we got released from the hospital after 29 days, ended up driving directly to my office and released her lip tie. And that same 60 milliliters, which 2 ounces for her to drink that had taken 35 minutes, I released the lip tie, handed her a bottle of breast milk, and she downed the whole 60 milliliters in 5 minutes. Within 24 hours, she got from 60 milliliters to 140. So that's a 230% improvement just with the lip tie release. And it just really showed me and felt good on my heart afterwards because I was able to make such an improvement. But my wife was right next door when I was doing the lip tie release, and 2.5 years later, and a year and a half of breastfeeding later, she still hasn't forgiven me because baby cried so much.
Well, I think
I
that's
see.
just such a poignant story. And also because, they talk about the story of one. When we generalize the population and think about this in terms of the bigger picture, it's these personal stories that really advance how we look at function and also institutional education. There are many gaps inside of, and your ability to come around to the other side. You wrote about this. I just want, there you have a blog about it that I think is really beautiful, and we can, reach out to me and I'll make sure that you can get access to this. But I do feel like, these stories are really important, and these cases that help really bring in the functional relevance to everything we're doing, no matter where you're coming from. So thank you so much for sharing that, Nick.
Absolutely. Thank you all.
Yeah. We have no more time. So Joy, do you want to unmute yourself? Joy Moeller.
I thank you so much for this meeting. It's fantastic. I don't treat babies, but I see the results of not treating babies every day. And we all need to thank all the early people that are doing this, because I see horror stories. I had an adult with a buccal tie who had been everywhere. We released the buccal tie and her teeth, which were inward, went out. And all of her symptoms, including speech, improved so much she could work with other people, because before that, she sounded horrible. And so buccal ties are important. That's all I wanted to say. We need to look at them.
Yeah. Thank you. And Stephanie, last question, and then we're going to close it out for today. Go ahead.
Hi, Samantha.
Hi.
Yeah, I'm a pediatric dentist. I work in Quebec, Montreal, up in Canada, and I've been doing these lip ties for over some 20 years for babies, newborns. And I don't know if you've heard, 2 years ago, we really had here in Quebec a dentist who had a very, very bad luck with the newborn. Following a lip tongue tie release, well, the inevitable happened. The baby died in the office. So here in Quebec, everybody stopped doing it for the past 2 years, including me, because it's a scary situation. And up to now, the coroner cannot give out a report because they don't know what is there. I've been looking through the literature. The attorney called me to see if I could act as a defense. And I've been looking through all the literature and I cannot find a connection. So I was wondering, I was so happy to hear Eyal speak, because I wanted to talk to him about this, if he's heard of anything, because we can't help babies anymore. And it's really, it's devastating for us, because we want to help the babies, but we don't want to cause any, problems. So maybe if you can just, yeah.
That's the extremest I've ever heard. There are cases of bleeding, and the coroner's report is an essential. But there's something like that happened in Japan many years ago with Yasuo Ito. who was a surgeon that was doing a lot of tongue release 30 or 40 even years ago. Like I showed you that in Japan in 48, this was a common practice.
Mhm.
And then I think it's because of the group of Mukai, the Mukai group that were releasing both for children, and they have great research behind them, releasing the tongue and releasing the genioglossus muscle, all the heads of the genioglossus muscle all the way down, and they in order to open the airway. And this is a very, very invasive procedure. So I guess complications are much more common there. And they banned releasing of tongue by, I think, by pediatricians in Japan for years. I was there with, I think, 7 years ago. No, maybe a little bit more. And then they restarted looking at that. I hope I helped restart the practice of releasing, because it really is so sad to hear. I haven't heard about this case, and it's weird that those that are against didn't use it as a tool to get back at us all over the world. But it's very sad. You should
So it
get
wasn't, yes, it
our
wasn't,
huge community.
it wasn't due to bleeding. It was really due to
Bleeding.
airway problem. So it
Maybe
just, the baby
it
just stopped
was-
breathing. So
There are cases of a retrognatic jaw, like a periodontist-like patients, and there are several cases of complication like that. I think even in Africa. No, Africa is bleeding, but cases of a periodontist-like patients that had glossoptosis, meaning the tongue falls back in. But a man need to see the patient and decide whether his tongue is falling backwards, and maybe even give. And that's a big reason for lactation issues, a very retrognatic patient. And even when we see a periodontist patients, we put them on their bellies with their head lower. So I wouldn't touch something like that, and I wait until they have enough tone, muscle tone, because feeding is one thing, breathing is more important.
oh yes, and to answer the questions in the chat, yes, they did use a laser with water. So maybe with aspiration, no?
I don't think so. It's more likely if he's a retrognatic that he had a glossoptosis. But
And to prevent that, you would turn it right away, like you said.
I wouldn't do it. If there is a chance,
okay.
I wouldn't do it on a retrognatic child that when he cries, you see the tongue falls backwards.
Okay.
I would wait a little bit. They need to be at least few weeks old to be in some kind of practice of feeding, or even supplement feeding, to gain enough strength. I draw that experience from the cleft of the periodontist patients that are deteriorating following their birth, because they cannot be fed well, and they are losing their muscle tone, and slowly, but within a few days, they cannot even be fed, and sometimes they get into GI and even tracheostomies and so on. So a person needs to know what are the cons of doing a release.
Okay, that
Okay, wonderful.
to conclude, only because we're out of time, but I want to highlight the conferences that are coming up. Eyal, your conference in Jerusalem, November 5th in Jerusalem. If you can put the link, I'm putting that information there. And then also Tongue Time in St. Gallen, Switzerland. I hope that you can all come to that. That's also in it's in Europe, obviously. So that is in January of 2026. So Micah, if you want to put the link on the chat, that would be fantastic. And I will be sending updates always, and conferences and events similar to this. So if you would like to join us and come to more, please sign up for a list that I put everything out into, and I'll just put that right here. So you just get updates. And if we do these kinds of events, that's really what it's about. So I just want to say thank you so much for being here. What an amazing turnout. This is so exciting. I know this is an international group and you all have wide backgrounds and disciplines. We have so many experts here in the room. So I just want to say it's such a pleasure to gather and be with you. And I really appreciate you coming. And Eyal, you did a fantastic overview and summary of so much of the literature that we really don't know about. So thank you, Eyal. Incredibly helpful. So anyway, have a wonderful rest of your weekend, everybody. So good to see you. And thank you for putting that link up. I really appreciate that.
I'll send it to you. I can't really do that. So
No worries. I will get this out. So just sign up so you get updates, because that's really what we do. So that's it. All right, everybody, have a fantastic rest of your weekend. And it's so good to see you all. All right, everybody. Bye.
Bye. Great to see you.